Hello, my dear candidates. How are you all? Hoping all are well. Is that my voice is clear, doctors?
Yes, ma'am, it's clear.
Yeah, thank you. So today nephrology session, actually I wait till 5 minutes, so I want to start because time is very important for us. And again another mock session will be started, so best to start soon. And again recording will be provided who miss they can hear again. So nephrology session, actually nephrology session, what they ask commonly. First of all, I want to discuss those topics commonly. My SLE candidates, my DHA had MOH candidates, remember very well that in nephrology there is a pre-renal, renal and post-renal part. So pre-renal means what, like this ureteric problem and urethritis, okay, any kind of stone, any kind of calcium reposition. Okay, so any kind of problem without renal impairment, like we using dye, okay, during angiography. So we have to choose this dye for angiogram. So it's a, we have to prevent renal impairment or renal failure by hydration method. Renal impairment like parenchymal change. If you see in CKD patient, there is a renal parenchymal change. So it's a renal impairment. Like a long-time diabetic patient develop renal parenchymal change. Post-renal, any kind of obstruction due to the ureteric and bladder, again like post-renal, any kind of obstruction that cause problem like BPH, benign prostatic hypertrophy. These are the obstruction, tumor, and allergic. The category was acute renal failure, chronic renal failure. Always they ask in the exam. So we have to understand what they're asking. This is the one part. Another part is vasculitis, like Wesner granulomatosis. Then polyarteritis nodosa. These are the vasculitis which impair kidney function. So renal vasculitis, acute shock, shocking causing renal impairment, we have to understand. This nephrology part, they ask many way, either acute setting or acute emergency, neither chronic setting. Okay. So I'm starting my session today. Acute kidney injury, it does mean that creatinine with which reduce urine output. When acute sedation, patient in shock, cardiogenic, hypovolemic shock, sudden, no urine output. Every day who are working ICU, CCU, they deal this type kind of patient, sudden cardiogenic shock, no output. In 24 hours, creatinine was 1 and next day it became 4 to 3, 5, 3 to 4. So sudden rising this creatinine, it causes acute kidney injury. So in case serum creatinine more than 26.5 micromole per liter baseline within 48 hours, I said within 24 hours or 48 hours. Actually, who in cardiogenic shock, hypovolemic shock, the time period 48 hours, it can be within 24 hours. So when creatinine rising more than 50%. So our creatinine value is 55 to 120. When it raises more than 55, so when it my marker is 120, it will be more than 220, 240, 300, like that way. Baseline within 7 days. Reduction of urine volume below a 60 kg male, if reduced within 6 hours, so 0.5 ml per kg if below. So 60 kg will be pass, urine output will be 30 ml, but it below 15 ml. So it's a renal impairment. So this way we have to calculate, though this just for basic. After passing DHA, many candidates will work in the critical care emergency, just to know that what is the acute kidney injury. Chronic kidney injury, chronically reduced EGFR or proteinuria. So chronicle, like a patient known case of the diabetes, known case of SLE patients, so nephritis, nephropathy, uncontrolled hypertension. So persistent reduction renal function less than 60 ml per minute, proteinuria passing albumin creatinine ratio more than 3 milligram per mole lasting at least 3 months. So at least 3 months, if SCR value more than 3 times higher than normal level. So it's a CKD patient. This is the very important exam topic. We have to understand very carefully acute and chronic renal failure. Very important, my dear candidates. Just listen very carefully. Acute means short history, means short days, short week. Chronic, long, month to year. Hemoglobin concentration always in CKD patient will find out low, cause we have to give erythropoietin supplementation, cause in CKD patient erythropoietin production loss. So we have to give artificially or injectable or subcutaneous form every weekly or 3-day interval. Okay, you who are taking dialysis or end stage renal disease, we have to keep this erythropoietin level within normal, though it's not possible because it can't produce erythropoietin because parenchymal damage already occurred. So we have to give artificially. But in acute setting, it will be normal. Renal size very important, my dear candidates, because they will give ultrasonography finding. It will be lower. So when size decrease, it is chronic renal failure. Renal osteodystrophy. Renal osteodystrophy only present in CKD patient. Peripheral neuropathy. Peripheral neuropathy, my dear candidates, listen very carefully that peripheral neuropathy only develop in CKD patient, that tingling numbness due to hypocalcemia. In CKD patient, actually, we know it's a secondary hyperparathyroidism. So calcium will be low, there will be the hypocalcemia picture. Serum creatinine concentration irreversible in CKD patient, but reversible if we correct the shock state, hypovolemic status, it is reversible. Okay, so this way you have to understand. Another very important topic, causes. Okay, causes we have to understand that pre-renal cause. Just before I starting my session, I given shortly. Pre-renal cause means sudden severe reduction in blood pressure. So sudden severe reduction of blood pressure, blood loss, dehydration, heart failure, sepsis. This is the pre-renal. Okay. Intrinsic renal means renal changes. It could be any drug cause, prolonged hypertension, any toxin, any vasculitis. Post-renal cause, I already discussed that any obstruction like BPH, cervical cancer, any metastasis, and prostatic cancer, these are the cause. We have to highly remark this point because these are the exam question: pre-renal, renal, and post-renal. I will discuss because this today actually theoretical information more, but today question is not so like before. So I want to discuss one by one. So Dr. Donilda, are you here? Try
Yes,
to
ma'am.
attend. Yeah,
Yeah,
try to
yeah,
participate this question.
yes, ma'am. A 60-year-old male with a history of benign prostatic hypertrophy, complaining of nausea, vomiting. Laboratory rules include sodium 145, blood urea nitrogen 45, creatine 2, urea sodium 10, urea creatine of 80, urine creatine, sorry. Which of the following is the most likely diagnosis? Um, I think it's glomerulonephritis.
Dr. Donilla, first of all, you read the question that patient history of BPH, right? And patient complaining of vomiting. You're hospital patient and you are a doctor, you are managing the case, that you see sodium within normal list, blood urea nitrogen is 45, creatine 2 means what? Creatine 2 means it's higher level because normal
Hmm.
level is 0.8, so it's a higher.
Hmm. Hmm.
Urea sodium is 10, it's a lower bit higher level, and
Hmm.
urinary creatine is 80. So actually, as you are doctor, I'm asking, ma'am, I have a BPH, I'm suffering a lot, but I'm now frequently vomiting, and you already done an investigation which reveals creatinine high, sodium up to the higher mark 145, urinary sodium is little bit high. So if I ask Dr. Donilla, is
Hmm.
it possible for having glomerulonephritis anytime? Is it possible any infection here? No, it's not
No, no,
possible.
no, no, no.
Not
Yeah.
possible. Okay, okay, then Acute tubular necrosis. Is there any shock that severely damaged? Is it possible B option?
No, no.
No. Okay. Now
It's
I have two
pre-renal,
options.
pre-renal,
Uh,
pre-renal, I
yeah,
guess.
it's a prerenal. It's a prerenal. Excellent. Cause
Yeah.
there is no clue for postrenal. Cause I'm starting vomiting. You are finding
Okay.
creatinine high, so
Okay.
it's causing prerenal cause, right?
Yeah.
So it's a
Okay. Yeah. Yeah.
prerenal
Pre-renal
failure.
failure.
Clear?
Okay. Yeah.
Clear
Yeah.
now?
Got it. Yeah.
Okay.
Yeah.
Thank
Got it. Thank you.
you.
Okay. Thank you.
So welcome. Prerenal failure. So see hypoperfusion. Hypoperfusion. So already vomiting only 1 point. Hypovolemia, dehydration, blood loss, low oncotic pressure, low albumin. Okay. Congestive cardiac failure, there's no clue here. Constitutive pericarditis, there's no clue here. Renal artery stenosis, these are the causes for the prerenal azotemia. Only one clue is that hypovolemia due to vomiting, frequent vomiting. So prerenal cause, absolute hypovolemia, relative hypovolemia, reduced cardiac output, renovascular occlusion. Renal causology, as Dr. Donila says, the glomerulonephritis. So see, there's no renal pathology. Patient BPH patient, benign prostatic hypertrophy. So it's a pre-renal. Post-renal cause like ureter, vesicular junction, bladder neck ureter. There's no abnormality there. So we have to know the anatomy. If we know the anatomy, we can find out what is ongoing. Because if I know post-renal means ureteric, vesicular junction, bladder neck urethra, pelvic calcium problem. So it's a post-renal. If I know any kind of hypovolemic or prerenal, like I come to my hospital, I'm telling I have BPS for a long time now, I'm complaining of frequent vomiting. So it's obstructive and causing vomiting. So it's hypovolemia. Even uncontrolled hypertension. So ongoing renal artery stenosis. You are giving 2 to 3 drug, but my pressure is not controlling. So it's a pre-renal failure. So this way we have to understand causology and pathology I discussed from the first. Management of prerenal postrenal azotemia based on correcting underlying cause. So underlying cause is here BPS. So we have to either we can refer the patient in surgical unit, or the obstruction cause or hypovolemia we have to correct now immediately. This question will be discussed with me, Dr. Sabajisan. If Dr. Sabajisan here,
Yes, ma'am.
yeah,
In this scenario, IVP study done for a male and showed a filling defect in the renal pelvis. Non-radio opaque ultrasound shows echogenic structures and oscatic shadow. The most likely
hyperacusis.
diagnosis,
Mhm,
yes, ma'am.
mhm.
The most likely diagnosis is options are blood clot, B tumor, C uric acid stones, D none of the above. According to the scenario, there is a filling defect in the renal pelvis and non-radio opaque. Ultrasound is echogenic structures and hyperacoustic shadow. So
Yeah,
maybe, ma'am, it is due to uric acid stone.
yeah, excellent, excellent. It's the stone. First of all, it's the hyperacoustic. This is the point. If it is hypo, it will be the tumor.
Yes,
Okay.
ma'am. Then it will be
Hyperacoustic
tumor.
tumor. It's a hyper means stone. Thank you, Dr. Sawa. It's a very high exam question. So thank you. Uric acid stone. So you doctor prescribe allopurinol so to reduce the uric acid level in your blood and urine, and medication to keep urine alkaline. So to reduce the uric acid, we can prescribe allopurinol. So C, calcareous, non-calcareous type. Stone could be the calcium deposited or non-calcium deposited. Calcium deposited stone or calcium phosphate, calcium oxalate. So what? It will be the radio opaque hyperacoustic shadow. But for the non-calcareous like uric acid, Christian, struvite, and xanthin guanine something. So we have to see this is radio lucent, not radio opaque. It's a lucent. So it's hypoacoustic shadow. Exam question, okay? For my DHA had MOS candidates, it's the exam question. The very important, very high topics for the exam, just to remember strongly these slides. So, my dear candidate, it's not easy. to remember, but if I read 2 to 3 times, I can remember. And this question we will answer by seeing this chart. I'll later discuss. First of all, pre-renal, identify acute renal failure. Pre-renal cause, urine osmolality will be more than 500. Intrinsic or acute tubular necrosis will be less than 350. This value must to know, they will give the value in the exam. Okay. Very important, just urinary osmolality value we have to remember. Post-renal value below 350. Sodium. Sodium value, acute tubular necrosis and post-renal failure always more. But pre-renal sodium value, as I discussed first with Dr. Donilla, that sodium was 10. Pre-renal. Okay, it was low. So sodium was 10, it was low. So it will be the below 20, it's the pre-renal. I was said it was high, but no, it was low. Blood urea nitrogen creatinine ratio, C, acute tubular necrosis and post-renal failure below. So if I remember shortly, blood urea nitrogen and creatinine ratio with sodium, these are the below 10 and this will be the more than 40, just shortly. And this is very important, sodium level, Dr. Donilla case, it was the below 1%, like that way. So this way, just remember till that. Very important, they'll ask in the exam. So now this question will be answered by Dr. Ramzan.
Okay, ma'am. All true for pre-renal failure except ma'am, it's urine osmolality less than 400.
Okay. Cause few Hallen's cast we will
Grading
find
time.
out. It will be remain. Okay, urinary sodium below 20, it is acceptable. Urinary specific gravity increase, so it's also acceptable. Serum blood urea nitrogen creatinine ratio will be the more than 20, so it's also, but except urinary osmolality, in which it will be the more than 500, but here it's a less than 400, so it is the answer, right?
Yes, ma'am.
Thank you, Dr. Ramzan, nicely said. So in pre-renal failure, we already discussed it will be the more than 500, but here less than 400. So this question, second question, will be discussed with me, Dr. Solomon. Question will be little bit
Hello.
hard, but we can discuss.
Hello.
Okay, we can try. Yeah, Dr. Solomon, your voice is
Hi.
not clear. Yeah.
Okay. A 60-year-old female complained of muscle weakness, fatigue, and polyuria for the past 3 weeks. Examination review result was basically normal. Heart rate 80, blood pressure 120, 80, temperature 37.5. ECG shows U wave and a flattened T wave. Blood test results, carbon dioxide shows 20, sodium 130, chlorine 90, potassium 3.0 milliequivalent per liter. Increased renin level and a normal glucose concentration. What is the most likely diagnosis?
So Dr. Solomon, after reading the scenario, what are the clue you find out? But there is a many information you got it, right? So
Yes,
tell me
yes, ma'am.
1, 2, 3, ma'am, these are the information I got. And just exclude
All right.
that. It is not possible, it is not possible. Okay, this way.
The clues here are there's muscle weakness and fatigue, then there's polyuria, which has been for 3 weeks. Now,
Okay.
the vital signs are normal, although the ECG shows that there is a U wave
U
and
wave
there is
and
flattened T
flattened
wave.
T. Means what? Hypokalemia, right? Means
Yes, ma'am.
hypokalemia. So
Yes,
it
ma'am.
means there is a hypokalemia. In our serum value also potassium low, potassium 3. Right?
Yes, ma'am.
Hypokalemia there. Okay. Another?
There's increased renin level.
Increased renin level. Increased renin level. Okay, and sodium
Yes.
also low, right? Low sodium.
Yes. Yes, ma'am.
Okay. So first of all, I want to read from E to A. So is it possible type 4 renal tubular acidosis? In renal tubular
No.
acidosis, there's no possible. There's no clue for renal tubular acidosis, like any Sjogren's
Yes.
syndrome, any misconnected, no, nothing,
No.
no clue here, right?
No.
Type 1
Yes, ma'am.
renal tubular acidosis also not possible because type 1 renal tubular acidosis associated any drug pathology, there's nothing, right?
Yes, ma'am.
There's no renal tubular acidosis or acidemia because bicarbonate level only 20 is okay.
Yes,
Second,
ma'am.
Cushing. Cushing is possible or not?
Pushing is possible, but I'm going for Crohn's syndrome.
You are going for Crohn's syndrome, right? Cushing is not
Yes, ma'am.
possible. You said there's no bruise, there's no stria, there's no BMI, it is not possible. But Dr. Solomon, for Crohn's syndrome,
Yes, ma'am.
what about blood pressure? What about blood pressure? Is it low, normal, or high? 1 point only. Tell
The,
me.
the blood pressure is normal, yeah. 180, 120, 80
Blood pressure will be the
is normal.
blood pressure in
According
Crohn's
to
syndrome
this.
never in Crohn's syndrome blood pressure never normal. This is the point.
Okay,
In
no.
Crohn's syndrome
Okay.
by blood pressure always high, always
Ah,
high.
yes.
So if it is I do excluding method, yeah, hypokalemia, normal blood pressure. So barter only the point in which normal blood pressure, hypokalemia is the point. But Crohn hypertension, there is no point. Hypertension is excluded. Clear, Dr. Solomon?
Yes, ma'am. Perfectly, ma'am.
So, so what is the answer?
Bartter syndrome.
Barter's. Yeah. Thank you, Dr. Solomon. This is the way that
Thank you
we are
very much.
discussing. So, see, Bartter syndrome, primary deficiency in sodium chloride reabsorption from loop of Henle. So, primary deficiency sodium chloride reabsorption, causing high renin. Already in my question, there is a renin is high, but normal BP, like Dr. Solomon said, it's a constant. In C, in Crohn's, there is a high blood pressure, hypertension, hypernatremia. So all goes against my diagnosis, Dr. Solomon. C, the triad. Crohn's triad, hypernatremia, high blood pressure, hypokalemia. So all high except hypokalemia. So it's not Crohn's. In my question, high renin, aldosterone, normal blood pressure. So high renin means hypokalemia, hyponatremia because this aldosterone is high. That's why. So primary hyperaldosteronism, serum hypokalemia, hypernatremia, increased BP. So it's a Crohn's syndrome, primary hyperaldosteronism. But renal tubular acidosis, no. It's a deficiency of ammonium chloride and hydrogen secretion, serum hypokalemia, but high sodium. So hypokalemia but sodium chloride will be the high in type 1 renal tubular acidosis. Type 4 renal tubular acidosis always common is chronic renal failure, aldosterone insufficiency or mixed connective tissue disorder, high potassium chloride and low sodium. So all are goes towards Bartter syndrome. So see, Bartter syndrome is the autosomal recessive salt losing tuberculopathy fucosemide type, BP normal and hypercalciuria due loss of lumen positive voltage rated necessary paracellular absorption. So see, Bartter, Gitelman, Liddle, we have to know very well. Gitelman, Liddle, always I have to differentiate by blood pressure. Okay, Gitelman blood pressure will be the low, in Liddle it will be the high. Urinary chloride, Gitelman will be the high, in which Liddle will just, it will be strongly remembered. That's it. Because in exam, they'll commonly give Bartter cone, or if they give Liddle, we have to differentiate. Just remember in this chart, serum potassium, all are low. Okay, this way we have to remember. Good pasture syndrome, my MOS candidates, very commonly they ask from the good pasture. We have to remember good pasture, rapidly progressive glomerulonephritis, pulmonary alveolar hemorrhage. So what happened? Here's a renal and lungs problem. Here progressive glomerulonephritis along with pulmonary hemorrhage. So hematuria, hemoptysis. We have to do initially anti-glomerular basement membrane antibody. We have to do kidney biopsy, most definitive. We have to see crescent glomerular, every point. My MOS candidates, listen very carefully, my heart candidates also, and every actually. Just I'm emphasizing the recall wise, that's it. So chest X-ray CT scan, we will find out interstitial infiltration. Lung biopsy will find out most definitive tests to see the pulmonary function. So good question. If we do a manometer, is a GP. Good means glomerulus, it's a kidney involvement. Question means pulmonary, it's a lung involvement. If I want to differentiate very high topics for the exam, Alport syndrome, Charcot syndrome, every topics, my DHA, heart, ACL, every topic is very important. Just listen very carefully. Test they ask the diagnosis. Just remember this chart. Alport syndrome, hemoptysis, loss of sight, loss of hearing, hematoproteinuria, these are the Alport, but Charcot, I have to remember asthma and eosinophilia. Asthma and eosinophilia. And P Anka will be PhD. So P Anka, Charcot positive. Wisner's hematuria and upper respiratory infection like epistaxis and nasal septum perforation. C Anka, very carefully after my session I'll post this PDF, extremely very important. This PDF I consult everything which they ask in the exam. So Wisner granulomatous hematuria, epistaxis and C Anka positive. Itching. Patient come to my hospital with itching. Is it CRF? Is it liver failure? Is it polycythemia rubra? Is it scabies? How? They'll give the scenario and they ask the diagnosis. So how? I have to diagnose. So first, if it is chronic renal failure, there will be serum urea high, serum phosphate high, erythropoietin low, peripheral edema will be there, and hyperpigmentation will be there. That's it. It's the itching. Diagnosis is chronic renal failure, liver failure. Ascites, jaundice, bleeding, but my important point is bleeding, in which bleeding never be with PRV, polycythemia vera, bleeding never with chronic renal failure. So my dear candidates, for bleeding, this point goes towards the liver failure. I have to remember this point. Polycythemia rubra, I have to remember this point goes towards the thrombosis, which causes stroke. Polycythemia rubra cause gout. Polycythemia rubra cause burning sensation. So we have to remember polycythemia rubra very strongly. So there's a 4 disease: scabies, polycythemia rubra, liver failure, chronic failure. 4 topics they ask in the exam. They'll give this scenario and I have to, is it CRF? Is it liver failure? Is it polycythemia rubra? Mainly they ask from the polycythemia rubra. So polycythemia question, hemoglobin will be the high. There will be the burning sensation along with the history of recurrent thrombotic lesion, DVT, pulmonary embolism this way. Rhabdomyolysis. So rhabdomyolysis, it is a condition of dying. Rhabdomyolysis, dying skeletal muscles. So our result, I'll find out myoglobin will be high, potassium will be high, and creatine kinase will be high. So trappered of several hours under heavy object fall followed by lying for long. So sudden severe fall down and it causes in the floor or an accidental injury or an IV drug abuser or any crash injury, so muscle damage, which causes myoglobinuria, hyperkalemia, and acute kidney injury or acute tubular injury. So there will be the increased creatine kinase. So prolonged immobilization, muscle ischemia, rhabdomyolysis. So I will find out my case. Either there is a crash injury or sudden fall down. I'll find out there is a hyperkalemia and there will be myoglobin, red color due to heme. So I'll discuss some brain trainer just for discussion, and why and what are the points here. It will be nice to us. This question will be discussed with me, Dr. Is Dr. Fatima is here?
Yes, ma'am.
Yeah. You will read this question and you will tell me the cause, why you diagnosis plus management.
An elderly man is found on the floor on his house. It is uncertain the duration he has been unconscious on the floor. On fluid resuscitation, he gains consciousness. His blood show creatine kinase 3523, serum urea 25, serum creatine 297. What is the most likely reason for the elevated creatine kinase?
So what is the diagnosis?
Mhm. Maybe rhabdomyolysis.
Okay. Rhabdomyolysis is the answer. So due to sudden fall down with severe creatinine kinase higher. That is the
Okay.
point.
Okay.
And in this case, creatinine higher, creatinine kinase higher, how will manage?
Mm,
How you will manage?
dialysis.
I have to manage hydration. If I do hydrate, it will recover soon. Okay. I
Okay.
have to manage by hydration therapy because on fluid resuscitation he gained consciousness. So when I had started the fluid, already patient started gaining consciousness. So it's the major part. I have to started fluid, right?
Okay.
Okay, thank you, Dr. Perry. Fatima.
Thank you. Thank you, ma'am.
So rhabdomyolysis management. So myoglobin is a nephrotoxic. It causes acute kidney injury. So I have to do IV fluid resuscitation first to remove to protect our creatinine and protect our renal function. Please or release of potassium hyperkalemia in ECG. There will be the tall T. There will be the white QRS. So I have to give IV calcium gluconate. Very important. Very important. Tall T, white QRS. I have to give IV calcium gluconate. This question will be discussed with me, Dr. Sajma.
Yes, ma'am.
Yeah.
A 21-year-old man presents with painless hematuria, which he has noticed in the last 3 days. He suffers from type 1 diabetes, which is well controlled but is otherwise fit and healthy. The patient has recently recovered from a mild throat infection. Urine dipstick analysis reveals blood and protein in the urine. The most likely diagnosis is number A. A is henoch-Schönlein purpura. B is benign prostatic hypertrophy. C is IgA nephropathy. D diabetic nephropathy, and E is urinary tract infection. So I think the answer is IgA nephropathy.
Why? What is the cause?
There is history of throat infection.
Mm-hmm.
So the painless hematuria, it might be, it may be due to the previous throat infection. In
Mm-hmm.
IgA nephropathy, there is previous history of any streptococcal or throat infection history present.
Is it within a week or within day? What will be the certain one said or within a week? What about this? How you will differentiate from post-stroke glomerulonephritis with
After
IgA
1 week to
nephropathy?
10 days, IgA nephropathy. In IgA nephropathy, it is around 1 week to 10 days, I think.
Okay. For post-streptococcal,
Sorry, ma'am.
for post-streptococcal glomerulonephritis, what will be the duration?
It will be 2 weeks.
I'll discuss. Okay. So you answer correct IgA nephropathy. I'll discuss. Thank you, Dr. Sajma. First of all, we have to understand very strongly the value of the duration. Always remember one point which done mistake, Dr. Sajma, is that long duration over week is a post-strokal glomerulonephritis below within days. I have sore throat 2 days back. Now I develop IgA nephropathy within short days. Dr. Sajma. Clear?
Okay,
IgA
ma'am.
nephropathy will not cross even week. Sudden onset or within days, within few days is the cause for the IgA, but it's long duration, 2 weeks or 3 weeks before it's the post-stroke glomerulonephritis. This is the point. I'll discuss any more. So the presence of red cause strongly suggests of glomerular pathology here. IgA nephropathy or Barger disease, most common cause of glomerulonephritis. So it can present any age. Hematuria can present hemicroscopic picture interval corresponding glomerular attack. Interval corresponding glomerular attack. Infection like pharyngitis exacerbate the condition. So IgA nephropathy, I have to remember interval attack in my glomerular pathology. It's a glomerular nephritis. Henochal nephropathy is another kind of glomerular nephritis. It's a vasculitis. Arthritis will be there, abdominal pain will be there, rash will be there, extensive surface of the skin. So, Berger disease or IgA nephropathy, painless recurrent hematuria, Dr. Sajma's case. Viral respiratory tract infection. After a very viral respiratory infection, red cell, red cast will be there. There's no specific finding clearly defined, but I have to remember initially I'll do exam question, no specific test, but IgA level I have to do. Most accurate test is renal biopsy. Both question, listen exam question. Accurate test, initially I will do IgA level, and most accurate test is the renal biopsy. Treatment. There is no proven effective treatment, but I have to remember steroids. Sudden, when it's sudden deterioration, I have to give bolus steroid to worsening proteinuria, and AC inhibitor used to prevent proteinuria as well. So sudden deteriorating. Actually, I start with steroid AC inhibitor both have renal protection, but steroid to prevent worsening condition, AC inhibitor cause decreased proteinuria. So, Dr. Sajma, remember, IgA begins days. Just remember days. Days were IgA nephropathy. Weeks for streptococcal glomerulonephritis. So, after 1 week, it's a post-streptococcal glomerulonephritis. Within days, it's the IgA nephropathy. It's the remember strongly, my DHA heart can strongly remember this point. IgA nephropathy, upper urinary infection, upper respiratory infection, gastroenteritis is the point, but for the post-streptococcal glomerulonephritis, it could be the pharyngitis skin infection, but the feature, this point is not for my strong point. My strong point in these days and weeks, and messenger IgA deposition, in which post-streptococcal, there will be the steroenzyme confirm the positive, which this infection, the steroenzyme test confirm the diagnosis. C3 level within the normal for IgA, but C3 level and C50 level will be the reduced. Just remember exam question, C3 reduced in post-streptococcal glomerulonephritis. This question will be discussed with me, Dr. Kufsia is here.
Yes, ma'am.
Yeah.
17 years old patient is referred by his GP after presenting with periorbital edema. The patient noticed the edematous eyes 3 days ago, but reports feeling unwell since a throat infection 3 weeks ago with nausea and vomiting in last weeks. A urine dipstick is positive for protein and blood, while serum creatinine and urea are mildly deranged. The most likely diagnosis is nephrotic syndrome, nephritic syndrome, renal failure, glomerulonephritis, and von Gretsch's tumor. Ma'am, the option, the correct answer is nephrotic syndrome.
Nephrotic.
Yes, ma'am. Maybe because patient is complaining of periorbital edema, and 17 years old. The duration is 3 days after throat infection.
3 weeks.
3 weeks.
And there is a blood. In nephrotic, no blood.
So it must be nephritic syndrome.
No. It's 3 weeks.
Okay, ma'am. So this must be glomerulonephritis because there is blood in urine.
Actually, this is the paid exam question. So actually, what happened? We have to understand this duration. Dr. Kusse, for you, my suggestion: calm and coolly read the question and try to understand. Like that, as you see, 3 weeks ago, throat infection, 1 point. So 3 weeks means I
Mm,
already discussed with Dr. Sajma's case that 3 weeks means is a glomerulonephritis, right? I
mm,
already 1 point. Second point, there is a blood. There is a blood. So it never be
mm.
possible in nephrotic, right? Even nephritic,
Okay,
because
ma'am.
in nephritic it will not be like that way. Glomerular nephritis will be the answer. Clear?
Okay,
So
ma'am. Thank you.
clear?
Yes, ma'am.
Glomerular nephritis, I actually discussed with Dr. Sashma's case. That's duration, very important. It is a part, glomerular post-streptococcal glomerular nephritis is a part of nephritis syndrome consisting of Dr. Kosia. It's a part of nephritic, but it's a consisting of it's a post-streptococcal. Because 3 weeks back I have a pharyngitis. That's why it's a post-streptococcal, but it is part. There is a hematuria microscopic, there is a hypertension, there is a proteinuria, and edema. So after seeing the edema, don't be confused by nephrotic. No, never possible, because there is a hematuria. Patient usually suffer from a streptococcal infection 1 to 3 weeks prior to presenting above symptoms, signs of nephritis syndrome. So, my dear candidates, nephrotic syndrome involve albuminuria. Just listen carefully. I'll discuss later more slides. There is very important exam topic, nephrotic nephritis. Always remember proteinuria for nephrotic. Albuminuria 3 gram per dl in adult causing edema. So hyperlipidemia will be associated with nephrotic syndrome. For the hematuria, it is associated with nephritic. This way I have to do differentiate, I have to correct my marks. Bone ghost tumor is not my headache because this is the renal cell cancer. These topics will not ask in my exam. Next question will be discussed with me, doctor. It's a Reza Uruji is here.
Hi, ma'am. 64-year-old woman with type 1 diabetes present to the clinic with several months of sinus problem. This is the clue, Wagner. And a 4-day history of oliguria. Her blood pressure is 137 on 80. Serum results show mildly elevated ura and creatinine. Absent of anti-GBM means it's not IgA nephropathy, while a C-ANCA assay is positive. It's enhanced or Wagner choice. And the red blood cell RBC casts are present. This is nephritis syndrome, not nephrotic, because there are RBC casts. And in the urine and her renal biopsy revealed glomerulocrescent. Glomerulocrescent means RPGN, rapid progressive glomerulonephritis. Then option are post-streptococcal glomerulonephritis, good posture, minimal change glomerulonephritis, rapidly progressive glomerulonephritis, and Wagner. It must be Wagner, option E.
Excellent. What are the point here, Dr. Reza?
Point here is sinusitis, recurrent sinusitis, and granulome is because of Wagner. And C-ANCA also another clue.
Wesner, excellent. Thank you, Dr. Reza. Excellent.
Welcome.
Thank you. So Wesner granulomatosis, Dr. Reza excellently done. That's a granulomatous vasculitis upper and lower respiratory tract in which there is a sinusitis frequently. We have to choose cyclophosphamide and prednisolone. Wesner granulomatous is a part of a small vasculitis that also includes Chastros-Wesner. So Chastros, there is asthma, eosinophilia, but there is no hints here in my scenario. So autoimmune disease, ANCA attack small to medium sized blood vessel resulting necrotizing granulomatous inflammation. So see, Wisner granulomatous autoimmune disease cause inflammation of the vessel. Wisner granulomatous commonly affect upper respiratory kidney and lungs. So this way, both I already discussed as chart, we have to remember this way. Acute tubular necrosis, very high topic. Just remember this question they asked from the emergency medicine. Acute once a shock, it causes acute tubular necrosis. So we have to keep hydration, fluid balance, hypovolemic shock, cardiogenic shock. So balance input output to avoid fluid overload. We have to take care balance input output. Aim to avoid negative fluid balance. So I have to take care regarding the necrosis. It could be the prolonged ischemia, reduced renal perfusion, massive hemorrhage, hypotensive shock. These are the causology for acute tubular necrosis. Very important emergency question they ask. Interstitial nephritis, very important. My dear candidates, interstitial nephritis drug, penicillin, proton pump inhibitor, or they ask from any kind of NSAID drug commonly taking for the RA patient, SCLA patient for the joint pain or osteoarthritis patient. Any drug related injury of the kidney, okay, there will be the there will be the mild eosinophilia, urine dipstick will be the bland, and there's no protein in blood, but there is a nephritis. So we have to do renal biopsy. So there will be the tubular inflammation and eosinophil and lymphocyte. So we have to give oral prednisone. So I am giving a case and it will be discussed. Dr. Badhun is here.
Yes, ma'am.
Listen my words and answer my question, okay?
Okay.
34-year-old female come to your hospital in your clinic decrease urine output and eosinophilia on urinary culture. She is a known case of RA and taking methotrexate. But right now, for few days, she taking more NSAID drug. What is your diagnosis and how you will manage?
Mm, okay, ma'am. 34 years old, known case of rheumatoid arthritis and on methotrexate. So, and came to hospital for you what? Eosinophilia.
Decrease urine output and you done urinary test, blood test reveal eosinophilia, urinary test reveal there is ESR CRP high.
Okay. Then it will goes for interstitial nephritis as here eosinophilia is shown. Patient is on methotrexate, so no. Then she takes NSAID. So I think the allergic reaction from NSAID, and that's the eosinophilia and urine output nil. So my diagnosis is interstitial nephritis. And
So tell me, manage step by step. What you will say and what is your advice?
okay, uh, what will I advise?
Stop the drug.
Yeah, stop the drug first of all. Then fluid resuscitation.
Fluid.
Then
And you will discharge the patient, right? This is
eosinophilia
OPD patient. So you will discharge the patient by giving
by giving prednisolone.
prednisone to decrease inflammation. Right?
Yes, ma'am.
Yeah. Thank you, Dr. Bazan. Excellent. So this way they ask in the exam. I have to find out that Dr. Bazan said NSS, though methotrexate is taking long time, but recently due to pain, she is taking more NSI. So this is the culprit drug. I will not stop the methotrexate because it is not harmful right now because patient telling me I am taking for a long time, but right now a few days I'm taking NSS because I am feeling more pain. So that way this is the long scenario. So I have to cut the scenario. Either they'll ask the diagnosis, neither they'll ask the what is the culprit for this scenario, which drug. So try to understand which drug. Don't mark methodism. Many candidates done methodism. So this is the wrong. Right now, patient taking NSAIDs. Right now, this is the culprit drug. So I have to stop it. I have to maintain hydration. Though I'll not admit this patient, there's no renal crisis. I'll discharge this patient by giving prednisolone. Thank you, Dr. Bhagan. So vitamin D deficiency in CKD patients. So see, I'll advise the patient with sunlight and skin with first hydrolation in the liver, 25 hydrolation calcification, and second hydrolation in the liver by 125. Actually, we give vitamin D to absorption of the liver to more signify the case. Like if we give this calcitrol active vitamin D, it will help in CKD patient to increase intestinal absorption of the calcium. In CKD patient, intestinal calcium is reduced, so I have to give this vitamin D to reduce serum calcium, lead to increased PTH level. So I have to say to expose in the sunlight, expose, take more calcium vitamin D to minimize the presentation. This question will be discussed with me, Dr. Hira Babar.
Yes, ma'am. Assalamu alaikum. 10 years old boy present for lower extremity swelling. He has a sore throat for 2 weeks and fever. His mother has noticed very dark brownish red urine over the past couple of days. He has no allergies. On physical examination, his blood pressure is 185 by 100 mm of Hg. Which of the following is indicated for the management? Option A, AC inhibitors. B, diuretics. C, erythromycin. D, oral prednisolone. And E, it's penicillin. Ma'am, it's the treatment is oral prednisolone.
I can
As
read the
there's no,
question. I can read the
it's 10
question.
years old boy. 10 years old boy, with lower extremity swelling. He had sore throat for 2 weeks and fever. His mother has noticed very dark brownish red urine over the past couple of days. He has no known allergies. On physical examination, his blood pressure is 185 by 100 mm of Hg. Which of the following is indicated for the management? Ma'am, BP is high, age is 10, 2 weeks back, so he suffered from sore throat with fever, and urine color is very dark, brownish red urine. He has
So
no
it
known
is
allergies.
the two is, so it's the diagnosis is
Yes, hi. So, ma'am, it's
the diagnosis is this question was discussed. Diagnosis is 2 weeks. 2 weeks history. BP high.
BP high, and there's dark brownish red urine and sore throat.
Urine.
Ma'am, it's glomerulonephritis?
Acute.
No.
Acute glomerulonephritis. So acute glomerulonephritis, I discuss in nephrotic syndrome, we use steroid and we use AC inhibitor, but it is nephritis, not nephrotic.
Yes, ma'am, nephritis.
So,
BP is high.
and in acute nephritic, most appropriately, we have to treat underlying infection. Okay.
So,
So what
penicillin,
is
ma'am?
penicillin? Answer is penicillin. So this is where we have to understand that nephritic syndrome. So see, very important. Steroids do not have any role in management, Dr. Hira. Post-streptococcal glomerulonephritis, I have to treat underlying infection. We'll give penicillin. If it is allergen, we can give erythromycin. But I'll give penicillin, but there is no sensitivity. Children 5 to 12 years, my age of the scenario was 10 years, 1 to 2 weeks after streptococcal pharyngitis, 3 to 6 weeks after skin infection, impetigo, edema, hypertension, hematuria. These are the triad of my scenario, Dr. Hira. These are the your scenario. Edema
Yes, ma'am.
there, hypertension there, hematuria
Yeah.
there.
Hmm.
So I have to give penicillin first, erythromycin if penicillin allergic, or supportive treatment. Supportive treatment means what? Sodium restriction, diuretics, fluid electrolyte management, antihypertensive. It's a glomerulonephritis. Clear or not?
Yes, ma'am.
So if you ask me, is that we can't give this? If you ask me, can we give? So see, actually, if I show the previous picture, it will be nice. You can understand because it is very important to understand this. So Dr. Hira, see, in nephropathy, we give ACE inhibitor ARB, but in post-streptococcal glomerulonephritis, we treat
Give
hypertension, we give
furosemide.
furosemide. Okay.
No
Yes,
diuretics.
ma'am.
Okay? Okay?
Yes, ma'am.
So, post-strokal glomerulonephritis, we treat SC inhibit. Post-strokal glomerulonephritis, we control hypertension and we give furosemide. But IgA nephropathy, it's also nephritis. But you have to remember that in IgA nephropathy, we can treat hypertension by SC inhibitor ARB. We can also give the steroid. But for post-strokal glomerulonephritis, our main point to treat the infection. Clear or not?
Yes, ma'am. Clear.
So see, diagnostic testing is the urine acid dysmorphia, RBC, RBC cast, low C3, positive throat culture, NTDNS antigen will be the positive. Pyelonephritis. Pyelonephritis presentation with the contributing factor stone, vascular reflux, diabetes, dysuria, frequency, urgency, lower abdominal pain, fever, rigor with the pyelonephritis presentation, lower urinary infection. So chronic case, hypertension, repeated urinary infection. These are the chronic case pyelonephritis. For acute case, fever, rigor, low in pain. Pyelonephritis question, causative organism or causative factor, recurrent vascular reflex or diabetes patient, and this presentation will be the rigor urgency. We have to diagnose this management urinalysis to see the blood protein urine culture sensitivity before commencing antibiotic. So start empirical antibiotic immediately, and most common organism for the pyelonephritis is or it is the E. coli. Management of pyelonephritis is the choemocyclar cephalexin, generally 7-day course. We have to remember this way. Proteinuria, very important. I have to understand that proteinuria can be normal, can occur in pre or post-exercise seizures, CCF, severe acute illness. So proteinuria can be post-exercise, congestive cardiac failure, acute illness, extreme cold. But if no symptoms and healthy, repeat the test. If healthy but proteinuria passing, we have to repeat the test. If 24-hour urinary chelation, urinary albumin creatinine ratio, you have to see. So see, do not refer to renal clinic because of one isolated positive dipstick. If it is confirmed, we have to send the patient in renal care. If one isolated proteinuria, no need to be worried. It could be any illness, it could be any cause. This chart, I was starting from the first, very important, nephrotic and nephritic. Nephrotic, insidious onset, abrupt onset nephritic edema. For the nephritic edema is lesser amount. Jugular venous pressure will be raised in the nephritic. proteinuria massive in the nephrotic, hematuria massive in the nephritic, and albumin low in the nephrotic. This chart is strongly important for the exam. Major difference nephritic and nephrotic is the amount of proteinuria. We have to remember this proteinuria will differentiate from the nephrotic and nephritic, not RBC. RBC may not be present in nephrotic. Commonly remember no RBC, that's it. Prerenal, postrenal, just I discussed this blood urea nitrogen creatine ratio, urinary sodium ratio, we have to remember. Low C3 level question, exam question, my DHA candidates, low C3 level, they ask SLE, cryoglobulinemia, postutography. This chart very important, remember. ESRD patient, the patient presented with anemia, pruritus, bleeding, hypocalcemia, hypophosphatemia, hypermagnesemia. So I have to manage by this way. If there's a pruritus, I have to do dialysis if needed, if interstitial renal disease. If bleeding, DDAVP. If there's hypocalcemia, vitamin D and calcium supplementation. If hypermagnesium, we have to give high magnesium fluid and laxative and antacid to prevent hypermagnesemia. So this way you have to do manage ESRD patient. Nephrotic syndrome, already I discussed this, proteinuria more than 3 gram per 24 hour, hypoalbuminemia, edema, hyperlipidemia, hypercoagulable stats. So any nephrotic syndrome, previously my group there's a discussion, nephrotic syndrome itself causes DVT. It's a hypercoagulable state due to decreased endostromin factor. So we have to do the investigation, protein creatine ratio, blood test albumin level, and definitive test is renal biopsy. Complication very important is embolism. Common cause of nephrotic syndrome in children, most common minimal is exam question, minimal change disease for the children, adult membranous glomerulonephritis. Secondary common cause, focal segmental glomerulonephritis. Other pathology could be the diabetic, myeloma, and amyloidosis. Remember, most common cause of nephrotic syndrome in adult more than 40 years is a membranous glomerulonephritis. Is a paid exam question. Minimal change nephropathy. Minimal change nephropathy, my dear candidates, remember, common children, proteinuria more than 3 gram, edema, hypoalbuminemia, normotensive, renal biopsy showed fusion podocyte, exam question, fusion podocyte, minimal change, this is exam question. 6-year-old boy swelling of the face, fluid urine, fusion podocyte. So what is the diagnosis? Diagnosis is the minimal change nephropathy. Minimal change nephropathy, now brain trainer, just I'll discuss this question with what we'll do. This question will be discussed with me, Dr. Moshumi. If Dr. Moshumi not here, Dr. Okay, Dr. It's a Maha woman is here.
Yes, ma'am.
Yeah.
A boy present with serum albumin 20 gram per liter, edema and urine dipstick positive for protein. What should you check before referring this boy to nephrology? Urine
Yeah.
creatinine ratio. We have to
So
check.
see, to confirm the is it truly impaired or not? Urinary
yes,
protein creatine. So urinary protein creatine ratio, right, doctor?
Yes, ma'am.
Minimal changes. Okay, thank you, Dr. Maha. So urinary protein creatine ratio, we have to check to confirmation for the minimal changes. Thank you, Dr. Maha. So hypoalbuminemia, hypovolemia, so see there's a vomiting diarrhea history, there's dehydration, hypokalemia history, acute kidney injury, patient presented with hyperkalemia, serum urea high and serum creatinine is high. So remember hypovolemia presentation and the picture, this picture very important in the acute tubular necrosis or acute kidney injury patient for the hypovolemia. So contrast induced like IG nephropathy or after doing the coronary angiography, we use dye. MRI, we use contrast. So contrast induced nephropathy, exam question, my DHA candidates and my MOH candidates. Contrast in ever my acyclic countries also. Contrast induced nephropathy, we do hydration to prevent contrast induced, like stop nephrotoxicity if renal function abnormal, metformin, NSAID. So to reduce risk of contrast induced nephropathy like CT scan or any other MRI angiography, we have to stop metformin, NSAID or any renal impairment, and we have to maintain hydration fluid 24-hour, 12-hour fluid before and after. Pre-postrenal contrast, particularly high-risk patient and elderly patient, diabetes patient, CCA patient, these are the risk group. We have to maintain hydration. Blood gas abnormality I discussed very commonly, very important already. I discussed many times. Respiratory. Even as today morning, I already posted very important slide. Keep carefully read those slides. Very important slide I posted today morning. Acidemia and alkalemia, respiratory alkalosis, acidosis. I already discussed. I already posted nice slides. Remember those way renal compensation. Just remember strongly if it is bicarbonate high, but renal compensation by respiratory acidosis this way. Hypertension, chronic kidney disease, CKD, non-diabetic, diabetic. So diabetic, we have to start ACE inhibitor. What about the ACE? Albumin creatine ratio 30, albumin creatine ratio more than 3. So if EGFR below 30, we have to start ACE inhibitor. If below 30 or below 3, there's no contraindicated for the ACE inhibitor. Whatever the main thing is that diabetic patient, EGFR below 30, this is not a contraindicated for ACE inhibitor use. We have to use more than, though we use, we actually practice more than 30 EGFR value, we use ACE inhibitor. Below 30 we don't use ACE inhibitor. This is the protocol. But eventually they are telling, eventually if we use below 30, no issue. But remember, for exam, we use till 30. EGFR value till 30, we use ACE inhibitor. Nephritic syndrome presentation, C, hematuria, hypertension, rapid onset, good posture, hematuria, hemoptysis, C, ANCA, vasculitis, and present in nephrotic syndrome, proteinuria, edema, minimal change disease, steroid, good prognosis, fusion porocyte there, mostly idiopathy and Hodgkin or steroid. So this way, just remember shortly this summary. The same things that one-third resolve and again recurrent way they discuss focal segmental nephropathy. This causology, focal segmental glomerulosclerosis, HIV or urine abuser. Okay, presentation, proteinuria, nephrotic syndrome and CKD, and nephritic young adult hematuria or upper respiratory infection 1 to 2 days ago. The presentation. CKD patient, we obviously will find out there's anemia, hyperphosphatemia, hypercalcemia, and small kidney size on ultrasound. It will be below 9 centimeter. So this brain trainer will be discussed with me, Dr. Somia.
Yes, ma'am. An elderly man with background of hypertension, diabetes mellitus type 2, and chronic kidney disease attends the GP surgery for checkup. His blood pressure is 180 by 100 and he's taking regular amlodipine. There is a significant proteinuria on 2 separate occasions. Which medication is likely to slow down the renal disease process? A. ACE inhibitors, B. Calcium channel blockers, and C. Diuretics. If the patient is elderly diabetic and is significant proteinuria on 2 separate occasions, and medication which is used to slow down the renal disease process is ACE inhibitor.
Okay. So your answer is?
ACE inhibitor, A.
Okay, so here main point is the hypertensive patient. Patient is also CKD patient, diabetes, elderly patient, and there is a proteinuria on 2 separate occasions. And to slow down this renal disease will help in ACE inhibitor, Dr. Somia. Right, excellent, thank you. So hypocalcemia patient present with tingling, numbness, persistent involuntary spasm, CKD can cause 125 dihydroxy vitamin D3 deficiency. CKD patient can cause decreased calcium absorption, hypercalcemia. So CKD presentation we know very well. ADPKD question very important from the neurology. They ask from the subarachnoid hemorrhage and from the nephrology. So hematuria, hypertension, low in pain associated with intracranial aneurysm, which cause bleeding. Ultrasound kidney showed there's ureter bladder. There will be the cyst. So autosomal dominant kidney disease ADPKD can lead to progressive CKD. So we have to do the genetic test to find out the inheritance. Polycystic kidney disease, so see hematuria, hypertension, we have to do ultrasound. Good posture syndrome, hematuria, hemoptysis, we have to do anti-GBM antibody, very important. We have to know remember strongly. Wilsner Gallomer, there will be C. Anka, hemolytic uremic syndrome, hematuria, bloody diarrhea. Hemolytic uremic syndrome, hemolytic anemia, uremia, thrombocytopenia, TTP will be the fever and neurologic presentations. The hemolytic uremic syndrome and TTP we have to do differentiate by neurological symptom. There will be thrombocytopenia in the hemolytic uremic syndrome, but TTP also thrombocytopenia, but there will be the neurological symptoms. So see, thrombocytopenia associated TTP, uremia can be present, but neurologic symptoms not associated with hemolytic uremic syndrome. So we have to do differentiate by this way. This already I discussed, very important, they emphasize there. ADPKD, large kidney and small kidney. So see, in large kidney, obstructive uropathy, size will be higher, hydronephrosis will be developed, and there is a multiple cyst. Okay, in small kidney, there is a bilateral renal stenosis, and there is a chronic pyelonephritis. Size is very important. The small kidney size, hypertensive renal disease, long-term high blood pressure, bilateral renal stenosis, AC inhibitor will choose, chronic pyelonephritis, recurrent UTI, and chronic glomerulonephritis, absence of diagnostic option of the proteinuria. So just remember, hypertensive renal disease associated with high blood pressure, we know very well. Bilateral renal stenosis, AC often worsen creatinine accurately. Unilateral renal stenosis can give. If it is AC inhibitor worsen, but unilateral renal stenosis, we can prescribe AC inhibitor. Chronic renal pyelonephritis, we use. There's a scarring in the parenchyma, we can use AC inhibitor. There's a hypertensive renal change due to the size, obstructive uropathy, hydronephrosis. Ultrasound of the show large kidney. There will be reflux nephropathy. Frequent UTI cause reflux nephropathy, which cause hydronephrosis. Pelvic ulcer system will be the dilated, which cause abnormal kidney size. Hemodialysis, very important to know. In hemodialysis patient, when we do, if patient persistently high potassium, there's indication of hemodialysis. Acidosis, patient develop metabolic acidosis, fluid overload, anuria, no urine output, pulmonary edema, pericarditis. These are the causology for indication of the hemodialysis. So transplant rejection. So patient had transplant. There's a picture of the transplant, like treat hyperkalemia, give IV calcium glucose for the hyperkalemia. Do not treat all the above features, as kidney does not work, potassium and toxin will accumulate again. So remember, best treatment for the patient of hemodialysis is hyperkalemia. Pseudohyperparathyroidism, doctor remember, parathyroid hormone will be the high, calcium will be the low or normal, phosphate will be the rise, and parathyroid hormone will be the raised, because and result is not enough calcium being absorbed. So PTH will be the higher in pseudo hyperparathyroidism. Just remember, calcium will be the low or normal, but PTH, parathyroid hormone, will be the higher. Adynamic bone disease, shortly remember, vitamin D and calcium tablet we have to give to suppress the parathyroid hormone level, reduce bone turnover and bone pain, because this cause is adynamic bone over suppression of parathyroid hormone. So in contrast, anesthesia renal disease, normal parathyroid hormone, raised alkaline phosphate, low calcium level, so it causes adynamic bone disease and back pain in CKD or anesthesia renal disease patient. This question will be discussed with me, doctor. Dr. Nipuni is here. Okay, Dr. Is Priscilla.
Yes, ma'am. A patient is brought to the emergency department after a seizure leading to prolonged immobility on the sidewalk. He has dark urine and myalgia. What is the most urgent step in the management of the patient? So my diagnosis is rhabdomyolysis. I will do A, urine analysis is wrong. EKG is wrong. Phosphate and creatinine is wrong. So it's either B or D. I'll do CPK level, creatinine kinase.
A patient comes to your hospital in emergency. You are a doctor of emergency. The seizure leading prolonged immobility. Seizure. So
Yes, ma'am.
seizure leading prolonged immobility, and he has a dark urine. So dark urine myalgia already you done. So when rhabdomyolysis occur, electrolyte imbalance is what? Only one electrolyte imbalance which cause life-threatening. What is that? Only one.
Potassium.
Potassium will be
Yes.
high.
High. Yes.
So it is life-threatening. The all tainted
KG.
T wave. So we have to do say ask what is the most urgent. Patient already done seizure. Prolonged immobility. You already see that urine is dark. So means what? Bleeding. Dark means bleeding. Myalgia. So you can't wait for ECG. Hyperkalemia always life-threatening. When you see a patient in emergency, you have to do immediately a EKG to see any arrhythmia. All T wave cause sudden cardiac arrest. So you have to do EKG, right?
Okay. Okay. Okay.
EKG is the most urgent step in acute abnormalities case. The test you knowledge to show that abnormal severe muscle necrosis cause hyperkalemia, it leads to arrhythmia. Hyperkalemia peak T wave. So we have to start initial intravenous calcium, gluconate, glucose, insulin. This is the management. But these are life-threatening, can cause sudden cardiac arrest as systole. Thank you, Doctor. Last question for our nephrology discussion today. Dr. Nipuni may be on duty, that's why not talking to me. One Fatima discussed with me, but another Fatima is here, still not discussed. Okay, Dr. Nipuni, no issue. One Fatima left. Okay, if not, Fatima is here, no issue. This question will be discussed with me, Dr. Saba Jisan.
50 years old male presents with a numbness of both lower limbs and right upper limb. Examination reveals pulse 88 per minute and BP 160 by 110 mm of Hg. He also has digital gangrene involved right, second, and third finger. Urine routine examination is unremarkable. Microscopic examination shows RBCs. Hemogram and serum biochemistry is within normal limits. What is the most appropriate diagnosis? A. Systemic lupus erythematosus. B. Pyeloarthritis nodosa. C. Malignant hypertension. D. Chagas syndrome. Ma'am, according to scenario, patient age is 50 and both lower extremities have numbness. On examination, pulse is 88 per minute and his blood pressure is 160 by 110 mm. And digits, second and third digit have a gangrene. Urine routine examination is unremarkable. Microscopic examination shows RBCs, and other labs are normal range. So, ma'am, it is A.
How?
Answer is
Okay. But is there any criteria for A?
mm, no, ma'am.
Dr.
Is
Hira,
polyarthritis.
you and Saba both will discuss this question with me.
Okay, ma'am.
Read and discuss. And Dr. Saba, you think
58.
and tell me. You already discuss and just think what may be the answer and why this is the
Ma'am,
answer.
Okay,
ma'am,
ma'am.
there is
Hmm?
Church stress syndrome is not possible,
Hmm.
and mm, SLE also not. Ma'am, it's
Hmm.
between polyarthritis nodosa and malignant hypertension. And there is numbness of both lower limbs and right upper limb. So, as digital gangrene, third or fourth gangrenous fingers. And RBCs are there on microscopic examination. And um, hypertensive. Mm, mm, Ma'am, it's mm,
Dr. Sajma, I'm discussing one by one because this question recall according to the exam recall. That's why. Dr. Sajma, what is the answer?
Ma'am, I think the answer is D. Church-Strauss syndrome because there is numbness of the hands and feet. Um, that's why I'm thinking about Church-Strauss syndrome, or it may be the malignant hypertension, but it will be on second due to the hypertension, but I'm not sure about it.
Okay. Now
yes,
another
ma'am.
candidate is Dr. Maha Umar. You can try.
Yes, ma'am. Ma'am, SLE, but if we proceed with excluding method, then SLE is not. Malignant hypertension, ma'am, not. And D, ma'am, if we proceed with D option, then asthma and eosinophilia may be
Yes.
present there. So by excluding method, the B option, polyarthritis nodosa.
Yeah.
Ma'am, polyarthritis nodosa because it involves the
But
arteries.
the upper and lower
So
limbs, yeah.
there is, ma'am,
Ma'am, B option.
gangrenous. B option, ma'am,
Yeah.
because
First of all, yeah.
second and the third digits having a gangrene, and gangrene is usually
Gangrene.
due to the arteries
Arteries
involvement
and
or
veins and arteries, respiratory
The
involvement.
high blood pressure is a vasculitis. It's a vasculitis.
Yes, ma'am.
Vasculitis, gangrene here, high blood pressure here. So, chest there is no asthma, nothing. It's basically nothing. Malignant
Yes,
hypertension,
ma'am.
nothing. So it's a pen.
No,
It's a
B.
polyarthritis nodosa exam. It's a
Nodosa.
MOS question. That's why I was asking exam candidate wise. So thank you, doctors, trying. And
Thank you so much, ma'am.
even so see, we are not understanding the question initially, but after discussing, we are confident. Yes, it is the point. Okay, so then inshallah in the exam it will not be wrong. Thank you. So polyarteritis nodosa question you have to remember. It's a rare disease, but it's a blood vessel. It's a vasculitis causing injury to organ system. The area most commonly affected pan include nerve and intestine tract, heart. So all systemic, heart, intestine, joint, all involved. So see this picture, all here. Polyarteritis nodosa in renal, there is a hypertension, oliguria. In GIT, abdominal pain, malabsorption. Libido reticulars in skin. It is affected mainly after 50 years of age. In pan, it's a systemic vasculitis. In ischemia, all over the gangrene, loss of blood supply, ischemia. There is a oliguria. There is a vasculitis, all picture. So it's a pan. polyarteritis nodosa, medium necrosis, inflammatory change all over the body. Clear?
Yes, ma'am,
ma'am.
clear.
Clear.
Okay. Today, nephrology session I concised high point I discussed because many topics also I discuss another way like surgery, like and another topics of medicine I discussed. So today my session ended. Hoping all enjoyed and try to practice. And today mock session will be posted soon. So thank you, my dear candidates. Assalamu alaikum to all.
Thank you so
Thank
much,
you,
ma'am.
ma'am.
Thank you, ma'am.
Yes, like salam.